I believe one of the most important advances presented at this meeting is ELEVATE-TN study, which led to approval of a novel second-generation Bruton tyrosine kinase inhibitor, acalabrutinib, in patients with treatment-naive CLL. So this study randomized patients to acalabrutinib obinutuzumab, acalabrutinib single agent, or chlorambucil obinutuzumab. And progression-free survival was significantly prolonged in patients who received acalabrutinib with or without CD20 antibody. And after a roughly 3-year follow-up, 90% of patients are still progression-free on this combination therapy. The overall survival was not different. However, patients were allowed to cross over from chlorambucil obinutuzumab arm to acalabrutinib. And what's also very important is that acalabrutinib was very well tolerated, and only 9% of patients discontinued due to adverse events. Another area of interest is that patients who progressed on venetoclax also seem to be able to respond to treatment with Bruton tyrosine kinase inhibitors. However, we need longer follow-up to establish duration of response in those patients. So this is a very good question. Now that we have a choice of BTK inhibitors, particularly in mantle cell lymphoma, 3 different drugs are approved. In CLL, we have approvals of acalabrutinib and ibrutinib. It becomes a very individualized decision. Overall, things that matter is drug-drug interactions. For example, both ibrutinib and acalabrutinib interact with CYP3A system, so I would strongly encourage physicians to look at concomitant medications, as that can increase toxicity. Acalabrutinib interacts with proton pump inhibitors, and those drugs should not be taken together. So some of the concurrent medications matter. In terms of other things, as ibrutinib is a non-selective BTK inhibitor, there are certain toxicities that it can cause due to inhibition of EGFR, such as rash, diarrhea, and there has been actually good studies, good results published in patients who were intolerant of ibrutinib due to different reasons, and then actually crossed over onto acalabrutinib, and most patients did well with it, with either reduction of the intensity of adverse events or complete disappearance of adverse events. So certainly we have a very good choice of BTK targeting agents now. One thing to keep in mind is that follow-up on acalabrutinib is still shorter, so it's still not clear whether the incidence of hypertension or atrial fibrillation will be similar to ibrutinib-treated patients or lower. We will need longer follow-up on those studies. Yeah, so that's a very good question, and certainly there are many areas where we see some problems. So first, patients with cardiac comorbidities, patients who already have a pre-existing atrial fibrillation. The question is BTK inhibitors the right choice for them? And as I mentioned a little bit earlier, second, patients who, for example, take oral anticoagulants, certainly warfarin, but even direct oral anticoagulants, as BTK inhibitors inhibit platelet function, again, that puts those patients at high risk for bleeding. Patients who have concomitant medications which interact with BTK inhibitors, cost is, of course, a significant problem. Particularly considering that BTK inhibitors are currently used until progression or adverse events, meaning essentially indefinitely as single agents in treatment of CLL. So one attempt to overcome this is use combination therapy with other novel agents such as venetoclax, a BCL2 inhibitor, and introduce time-limited therapy for those 2 drugs. And the results presented here at ASH are very good for both venetoclax and ibrutinib combinations and venetoclax acalabrutinib combinations. However, we still would need to know whether this results in improved survival or other outcomes, or sequential therapy is still the way to go. I believe we will be facing with ibrutinib progressions. or acalabrutinib progression. So BTK resistance certainly is a concern in CLL and mantle cell lymphoma. There are differences in terms of how those resistant clones develop. Clearly, with both ibrutinib and acalabrutinib, mutations in BTK is one of the primary mechanisms of resistance in CLL. And this data has been also presented regarding acalabrutinib at this meeting by Rick Furman and Jennifer Woyak. When resistance to those drugs develops and is due to this mechanism, then alternative agents will need to be investigated, such as venetoclax or venetoclax combinations. There is still a role for PI3 kinase inhibitors. For example, the U2 regimen, ublituximab umbralisib, has been investigated in CLL. However, there is not so much data in BTK-resistant patients, and I hope we will see more of this data in the future. Finally, the question is the combination approaches, which I mentioned earlier, whether they will overcome emergence of resistant clones on BTK inhibitors, even with time-limited therapy. That is a very important question to pursue.